Welcome to Fuller Butz, a behind-the-scenes plastic surgery podcast. Yes, you heard that right. Join your co-hosts, Dr. Sam Fuller and Dr. Dan Butz, board-certified plastic and reconstructive surgeons, on an exclusive full-access pass into the world of plastic surgery. Combining their expertise and training, Drs. Fuller and Butz will share medical insights, detailed explanations, and lighthearted humor to keep you entertained and informed. We're certain you'll become passionate about the plastic surgery specialty, and between debunking myths, uncovering truths, or just making you laugh out loud at their perspective on this creative and artistic field, we've got something for everyone. From tummy tucks to Botox and mommy makeovers to surgery do-overs, the Fuller Butz Podcast will surely satisfy your podcast fix. All right, now let's dive into this episode.
Hi there. Welcome back to the Fuller Butz Podcast, a behind-the-scene look at plastic surgery. I'm back with my co-host, Sam Fuller, and today we're really excited to have another special guest, Dr. Sahar Nadimi. Dr. Nadimi is a Chicago native and went to Northwestern for undergrad, University of Illinois Chicago for medical school, and then Loyola for your ENT training or otolaryngology. And then we actually kind of overlapped or did a similar fellowship in San Francisco, where she trained with a pioneer in hair transplantation, Dr. Kabacher. You've been back in Chicago for 8 years now and joined a very busy hair practice, the Chicago Hair Institute, but you're also doing a lot of other kind of facial aesthetic surgeries. But we thought you'd be kind of provide a lot of interesting insights into this world of hair transplantation. So thank you for joining us. I haven't seen you in probably 8 years. How have you been?
Yeah, I've been great. It's nice to see you, and thank you for the opportunity. Time flies. Here we are, like 8 years later, but everything's going well.
It's great. Three kids now, right?
Yes, I have 3 kids, 4 and under, and we're living in downtown Chicago, so kind of navigate the school system and, all of that stuff. But it's good. It's a lot of fun. So busy, but good.
Do you have twins, or is
No?
Okay.
I did it kind of like Dan. So I have a 4-year-old, almost 3-year-old, and a 15-month-old. So
busy times. I'm shocked that you have an hour to spend with us. This is wonderful. Thank you.
Yeah, I have a lot of help, so I couldn't do it on my own. That's for sure.
So we're super
really
excited.
Takes a village, that's for sure.
Mm-hmm.
Yeah. We're super excited because you're actually the first facial plastic surgeon, facial surgeon on our podcast. Over the last season and a half, we've been diving into different within plastic surgery, specialized procedures and topics and hot topics, but we really have sort of kept away from hair transplantation, hair regrowth, and so we're excited to talk to you about that. For our listeners and viewers, can you just tell us kind of about your path towards specializing in facial surgery? What were the goals that you had? What were the reasons behind it? And why do you love what you do?
Sure. So I started out in ENT, and from the beginning, I was really interested in facial plastic surgery. I loved head and neck anatomy in medical school. It was my favorite rotation throughout med school. I love art, and, the anatomy of the head and neck is very complex, so it drew me to it. And, so I knew, that I wanted to go into facial plastics from day one of my ENT training, but I, tried to keep an open mind, and, I loved all aspects of ENT, but facial plastics I was more drawn to that. So when I applied for fellowship, and I ultimately matched with Dr. Kabacher and Corey Moss in San Francisco, I remember Dr. Kabacher reached out to me and he said, there's one of the pioneers in hair restoration is in your backyard. You should go check him out. And at that point, I knew nothing about hair restoration. So that individual is Raymond Conyer, and that's actually whose practice I joined. So I went and visited him, and I just thought it was the coolest thing because I'd never heard of hair transplants except for those pluggy hairlines from the 80s and early 90s. But he was producing beautiful work, and I spent a good amount of time with him my 5th year of residency. and I maintained a good relationship with him. And then I went off to fellowship, and we did a lot more. We got a lot more exposure to hair restoration, forehead reductions, and other facial plastics procedures as well. But I ultimately came back and joined Ray Conier's practice. So like early on, I became very busy with hair restoration. And what I love about hair is that these patients are just so happy. Hair loss is something that people are incredibly self-conscious about. It impacts the quality of their life. So high quality hair restoration surgery leads to beautiful results. And I've seen people just transform, like during the initial consult, they're not really looking at you and they're not looking at your eyes, they're kind of look down and they're just quiet and reserved. And then you see them back a year later once the results have all grown in, and they're just like completely different personality. They're just very happy, and it's just high patient satisfaction rate. So that's really nice. It's really rewarding. And I also like, another thing that draws me to hair is just, all the like artistry that's required in creating a natural looking hairline. You have to create the micro irregularity, the macro irregularity of the hairline. It has to look very natural and feathered, recreating cowlicks, and you have limitations with every surgery. You have a finite number of grafts, and you have to make it work. You have to try to get the most coverage possible within these limitations that you have. So it's a really, it's a great field. And I think especially for people who do a lot of facial plastics, I think hair is really nice because it's very rejuvenating. If you've got someone who's got a very thinning hairline and you just do a hair transplant, all of a sudden they look a lot younger. So I think it's like a really good area if you're doing a lot of face work to build into your practice.
That's great. So what is your breakdown as far as hair restoration versus other facial plastic surgeries? Like what percent are you doing?
I mean, that varies depending on the month, but hair is anywhere between like 50 to 60%. And within hair, it's FUE or strip. We can talk more about that. FUE is probably more popular these days than the strip technique. I do a lot of forehead reductions. I know Dan has a solid training in that as well. A lot of rhinoplasties, and then, facelifts, neck lifts, eyelids, brows, a lot of brow lifts. I'll pair brow lift with forehead reduction pretty frequently.
Yeah, one of my favorite kind of memories from Dr. Kabacher is he'd be like, if you lose your hair early, you look a lot older. Like you were saying, like just rejuvenating your hair can make you look younger. He has a photo of himself with like a wig, and he like looks like he's a lot younger. And then he's like, but if you lose your hair when you're young, you never age. He's like, I look the same age since I was like 35. He's got this like series of photos where he literally looks the same from 35 to 75. So it's really, I mean, like you're saying, a very self-conscious thing for a lot of men and women. It's very common, obviously, and there's a lot of advertisements out there. So just kind of diving into some like the basics of let's start with non-surgical hair restoration. Like, what can people do to prevent restore some early thinning? Do these things like really work in terms of over-the-counter supplements, light caps, prescriptions? What are your general thoughts on that when kind of an early kind of thinning patient comes in asking for advice?
Hims and hers, my OR staff, I was telling them, like, we have a hair expert talking about, they're like, ask her about hers, ask her about Hims. Do those work? Like, tell us the reality.
Sure. So that is, that's like a multi-million, billion-dollar industry. You do a simple Google search and you get hundreds of hair loss treatments. And the problem is that, majority of this stuff just doesn't work. The good thing is a lot of this stuff is, it's not harmful per se, but it doesn't work. And you end up wasting a lot of money. So, after all these years, years and years of people trying to come up with something to treat hair loss, it all, basically it comes down to minoxidil and finasteride, we're down to, those are the two best treatments, and nothing comes close to it. I have patients who like try everything. They do PRP injections. Of course, they've done millions of, like so many people have done that. Light caps, micro needling. I don't know if you've heard this, where like you do the micro needling to get I've seen people like cause shock loss from doing it too aggressively. Supplements, shampoos. But, I always tell them, like, go ahead, you can keep, they always ask, like, should I do this? What should I do? I'm like, you can keep doing it. But, the main treatment, what you're going to see, the main treatments that are actually that have shown to be effective year after, time tested, proven to work, is minoxidil and finasteride. But I should say that it doesn't work for everybody, and it's not what these medications do. It's more to mainly it's preventing further hair loss. So it's not regrowing hair. So if you have a hairline recession and you want to lower your hairline, minoxidil, finasteride, that's not going to do anything, but it prevents further hair loss. It prevents it from growing back, because a hair transplant does not prevent further hair loss. It does nothing to stop the hair loss process. You're just rearranging the hair that's on your head. But medications like minoxidil, Propecia help prevent further hair loss in a good amount of people. I'd say Propecia is probably like 40 to 50% of people notice stabilization of the hair loss. Minoxidil probably around the same. The nice thing is minoxidil, for years and years and years, it's been a topical, but more recently it's prescribed oral formulation to treat hair loss. It's off-label, but a lot of people are using it for that purpose. And that tends to work better than the topical. It's, easier to apply. It's not a, topical that you have to apply all over. So I've been prescribing that a lot now. And I know probably 5 years ago, I started prescribing it. And I feel like I was the only one in my area prescribing it. But now everyone's coming in already on the oral minoxidil. And you mentioned Hims. I didn't, whatever those, basically, those are fine. Those are just, compounded finasteride minoxidil. I think now recently they added minoxidil to it, but before it was like finasteride, or they have a compounded finasteride minoxidil, or there's this other company I think called like Strut that does like a topical finasteride. So these are fine. These are just like taking the two things that work and just, labeling it something else, but those are the products. And then sometimes people who are not really responding to finasteride anymore, they will switch to dutasteride, but you have to be careful because that has a longer half-life, so potentially more side effects. But these are all like tolerated, well.
So to summarize, finasteride, minoxidil, yes, those work. Other supplements likely are not going to be harmful, but if you're seeing something for biotin or trying to strengthen hair and stuff, that's not necessarily going to stop hair loss or grow hair. It may provide some enriching nutrients, but it's not going to be a game changer for these patients who are suffering with that. Is that your...
No, I would even put PRP in that category.
What about FFP or some of the other things that feel like they're kind of just injecting a bunch of stem cells all the time in their scalps? And so that there's not a lot of hard concrete evidence that that's going to be useful.
Yeah, I remember a couple years ago, I was doing a lot. I mean, there was a big demand for PRP. If I started up again, there'll be enough, people will sign up for it, but I just did not see a difference. And we were charging a lot of money for PRP injections we were pairing it with A-cell, which is like a protein scaffold, and I didn't think it made a difference. So I just didn't.
It's tough when you can provide such like great results surgically, and these non-surgical things are like not really tipping the scale much to continue to encourage people to do it. I think when you go to a med spa, that's all they have to offer.
Well, that's what I do. I tell them, I always say, well, for me personally, I didn't see a difference, but if you want to explore it, check out the local derm or med spa, whatever. That's not something I want to be, famous for, because I didn't think it worked.
And there was like another trend with like exosomes or something. And all of it seems like there's we talked to last episode or a couple episodes ago about salmon sperm for, facial rejuvenation stuff. So there's all these like trendy things, but you're not seeing any, hidden forbidden fruit or magical way to do it. It's, time tested, either, prescribed medications or surgery.
Yeah. And I think exosomes, you can't inject them. I think that's
like the microneedling application, right?
It's just topical, I think. Yeah.
So my nurse practitioner wants me to ask on behalf of her husband, who has some hair loss, what's the truth behind genetics and hair loss? Should she be blaming, her mother-in-law's family line or father-in-law's family line? Like, is it paternal, maternal? Where does hair loss come from? What's the DNA basis for it?
It's a mixture of the two. So it's not, I wish it was that simple, but it's a mix, it's a combination, it's mom's side, dad's side. And the problem is it's unpredictable, it's variable. There's no way to determine, okay, if mom has this hair plus dad with this hair equals, you can have parents, great head of hair, grandparents, great head of hair, first kid, great head of hair, the brother, bald. Actually, that's like my family tree. That's my brother. But so it's just, I don't put a lot of stock into family history anymore. It used, it's on our consult sheet, but I like half the time don't even ask it, because even if, someone tells you no family history of hair loss, this is just, I've always had a high hairline, I want to lower it, I'm not at all worried about future hair loss, I want to do an aggressive hair transplant. I can't just assume that this patient will never have hair loss, because I know that's not the case. Some people, it kicks in their 20s. Others, it doesn't start until their mid 50s. You don't know.
Is it environmentally related, like people who wear hats all the time or use a lot of hairspray or something like that, or something that you're doing to cause this?
No, the only thing that causes hair loss from hairstyles is traction alopecia, where you might see it in gymnasts, or, when patients, it's very common in African American patients because they wear really tight braids. So they lose like the temples, the hairline, it goes back. So that, I guess is environmental, the way they style their hair, things like that. And braids are okay. You just don't want to like be pulling constantly. You want them to be a little looser. But in terms of like smoking, diet, this, that, no, that doesn't cause, that's not, it's ultimately, it's genetics for the majority of people. There are other causes for hair loss that we can get into that are, if you look at, alopecia is just a general word for hair loss. And under that category, the overwhelming majority of people, it's genetics, androgenetic alopecia, as the name implies, male or female pattern hair loss. A small percentage, it is thyroid related, hypo or hyperthyroid. It could be iron deficiency anemia contribute, low vitamin D, but everyone in the Midwest has kind of lowish vitamin D. And then very rarely you get like those, you can get stress related hair loss. Sometimes in association with surgery, we might see a little bit of stress related hair loss, but by definition, that always comes back, but it can take 6 months, but it always recovers. And then the real thing you want to be on the lookout for if you're seeing someone is a scarring alopecia. You want to make sure that they don't have that, because you don't want to operate on that. And that's basically an autoimmune attack of the hair follicle. And it leads to a lot of inflammation and ultimately just scar tissue. So the reason why you wouldn't want to do a hair transplant on those patients is because your hair transplant might not take, or it might take in the short term, but fail long term.
So, tell us a little bit about like how, a consultation works and like what your strategy is in the procedure. Like what if the difference of a 22-year-old comes in with pretty aggressive thinning, but hasn't really stabilized versus a, 35 or 40-year-old where it's kind of, stabilized, and what that game plan and procedure can look like. You mentioned strip and FUE, like what, can as simple in terms of as possible, what does that kind of look like for a patient?
That's like a book I could, that's like extensive.
Just the whole thing. Tell us everything about hair transplantation.
Yeah, I'll try to, break it down. So basically, patients, they're coming in younger and younger because they're seeing it everywhere. It's on billboards, at least in, Chicago. It's all over. It's, especially with like Turkey. Oh, fly to Turkey for $2,000. You'll see the whole country and you'll get a hair transplant. And we'll pick you up, drop you off, and airfare is included. Like it's medical tourism.
Yeah. My OR staff asked me if our hair expert was from Turkey.
Yeah, no. I'm a little more east, but so anyways, I try not to operate on patients like under age 26, just because their hair loss is not predictable just yet. So the problem is we have a finite number of grafts in our donor area. And, if a young guy, 21, 22 comes in and they have minimal hair loss, and then they're like, well, can you just bring it down, like 2 centimeters, 1 centimeter. So it's kind of like how it was, when I was freshman in college. The problem is if you say, oh, well, that's not a lot of grafts, you don't have too much hair loss, let's do it. You set the hairline here, and then 5 years later, they lose all this hair, then they're stuck. This is like a tattoo. This is permanent. They're stuck with this low hairline. You can fix that, but you have to punch out every single graft. It's awful. You want to avoid that. So an ideal candidate is someone who has, you can kind of predict their hair loss. So even in 30s, you can't predict it, but it's better than like a 21-year-old. So more time gives you more perspective. So for me, I prefer to operate on people, early 30s, but I have no problem operating on people in their late 20s. It's very common. But it's always nice to have a few more years under your belt to kind of see how their hair loss is playing out, because the plan would change. If you have minimal hair loss, fine, you can lower your hairline. But if you end up having advanced hair loss, you would never set the hairline there. You would set the hairline higher up. So the plan changes depending on how your hair loss pattern is, and you just don't know what it is when someone's young. So we like patients who are a little bit older for that reason. The donor area is really important. So the donor area consists of the back and the sides of your scalp. And not all donors are the same. Some people have higher density, more hair follicles per square centimeter. Some people have thinning in the donor area. So not everyone, you can have hair loss in your donor area. You can have extensive hair loss in your donor area. And if you do, that's where we're taking the hair from. So if it's real thin in your donor, you're not a candidate for a hair transplant, unfortunately. So if you have good quality donor area, that's great. You can do a lot. And then realistic goals, realistic expectations, because a hair transplant, we're not creating new hair. You're just rearranging. And that's actually something I didn't know at all about hair transplant until I started, visiting this office. I always thought a hair transplant means like you're creating new hair. You're not creating new hair. You're taking from one spot and moving it over. And in the place of where that hair follicle will be a scar. So it'll either be your strip scar or it'll be your FUE dot scars. So we're not creating new hair, and it doesn't help prevent further hair loss either. So patients have to understand that the amount of donor hair that one has is nowhere near what we once had over the whole top of the head. So they have to understand the, limitations of a hair transplant. And if, someone, for example, comes in completely bald, donor area not very good, and they are, their goal is a full head of hair, and they won't be happy with a higher hairline. They want full coverage, high density, front to back. They're not a good candidate. If you operate on that, they'll be very mad, So.
So what does FUE stand for?
Follicular unit extraction. So basically, FUE, follicular unit extraction, FUT is strip harvesting. So there's FUE, FUT has been around forever. I mean, first it was the plugs in the back. People took those big, like you go to a dermatologist, they do a big, skin punch biopsy. That's what people used to do. They used to take these big punches and take out 50 follicular units and just transplant them up here. And that's how you get those cornrows. And that's before the introduction of the microscope. Once the microscope and loops were introduced into hair restoration, that's when results became really good. Before that, everything was just done with the naked eye. And so it wasn't refined. It looked really artificial. So then it evolved into the strip, where you would take a strip out from the back. That strip is cut under a microscope into individual follicular units, and then transplanted wherever they need to go. And then the end result is a linear scar. It's just closed with stitches. And then over time, the next step was FUE, where we're punching out individual follicular units with a punch. And it's basically, an FUE graft and a strip graft, they look the same once they're prepared. It's just the method that in which they are harvested from the donor area. So strip leaves you with a line, FUE leaves you with little white dot scars in the place of where that hair follicle was.
What does that day look like for you and for the patient? Is that like on average, I know everybody's a bit different, but just say like a routine mid 30-year-old, frontal thinning hair with a good donor site. Is that a 4-hour procedure under local, or are they under anesthesia? I mean, what does that day look like for both of you? And maybe what's like the early recovery?
So we do it under local anesthesia and oral Valium. When I was a fellow, it was IV sedation. So, one of those. It's not something that's done at a surgery center, obviously, but usually it's just done in the office under local. It takes all day. So, with hair restoration, why people need to do a lot of research is because the offices, the way they do it, it's very, very different. In our practice, it's one patient a day. So you come in, say we're doing 1,500 grafts, 2,000. Usually I don't do more than 2,500 because that is an all-day procedure. Because in my office, I'm doing all aspects of it. I don't delegate the work to like 10 technicians and 5 of them are planting the grafts. I'm doing pretty much all aspects of the surgery. So ours take all day. And most people, it's, similar in that it does take all day. It's not a 4-hour. If something like this is 4 hours, you're in trouble. You're getting like a sloppy, that it's not going to be a good result. It's very, it takes a long time.
Yeah, because how the grafts are harvested, I mean, you need to core out that graft just in the right angle so you don't, transect the root. You need to place it in a, nice congruent pattern. You're talking about colics, all these things. Like it's pretty technically, detailed. And, again, we're talking about individual hair follicles. So
well,
it's
the thing that's tricky about FUE is that, so as the hair comes out of the skin, it's not just that part that you have to harvest. The follicle or the bulb or the root lies underneath the skin in the sub-Q layer. And so when you're doing FUE, you have to core out this entire hair follicle, and there's an element of blindness. You don't know how it's growing underneath the skin. And so, especially like, for example, patients with really curly hair, it's bending in all different directions. The angles, the directions, they're changing as you're going along in the scalp. So, I mean, you really have to pay attention to these things and, you have to be meticulous about it. So it's a long surgery. It's like all day. It takes longer than a free flap. I was talking to one of my head and neck colleagues, the other day. I'm like, yeah, our surgeries take longer than yours.
What do you counsel patients about, like the expectations of a potential second stage? I mean, are you able to achieve like pretty natural density in one round, or if it's, again, a pretty like more extensive, thinning baldness, do you expect or talk about potential second stage to thicken it up?
So there's 2 scenarios with that question. One is if you have someone who's completely bald, that's going to be a multi-stage thing. They're going to need something for the frontal half And then if they have enough donor area, mid scalp crown, maybe even potentially a third procedure if we're assuming if they're completely bald. So that would be multi-stage, and you want to tell them that up front, because if they think one and done, they're going to be not happy. So completely bald, we're looking at a multi-stage procedure. If it's something like, I have a hairline recession, or for women, naturally high hairline, I want to lower it, or men, just my hairline has gone back, I want to lower it. You can get a, very nice result, just one pass. But it should be noted that if you were to measure when you were a kid, the density, right here, for example, your childhood density had about 100 hair follicles per square centimeter, if you were to count. And with a hair restoration, the thickest hair transplant, the highest density hair transplant that I can do, anybody can do, is around 40 to 50 grafts per square centimeter. So even the thickest, best hair transplant is half of the density that you were born with, that your, pre-existing hairline is. But you only notice hair thinning when half the hair is gone. So if you can get close to that 40 to 50%, 40 to 50 grafts per square centimeter number, it looks really thick. And the reason why you can't do more than that is because you have to maintain the blood supply. In between each of these openings has to be like a little, microscopic bridge of skin, because that's your blood supply goes through there. So the nice thing is you only notice thinning when half of the hair is gone. So if you can get to that 40 to 50% density, for most people, overwhelming majority, it looks really thick. And that's crazy to think that if you notice thinning, already 40 to 50% of the hair is gone. But that's what it's known as. So if most people, 40 to 50% density, it looks really thick. But a small percentage of people will, they'll notice it's still like a little thin if I go out in certain lighting or if my hair is wet. And so, I always tell people, overwhelming majority of people are happy with a high density restoration. A small percent will want to come back maybe no sooner than a year, because it takes a year for the grafts to grow, and they might need a little touch-up procedure to make it kind of pop a little bit more.
And how long do each of those procedures take to recover from? Like, when can that person be social again, going back to work? What's the downtime?
Yeah. So, with FUE, you almost always have to razor shave the head. So that, it depends on the patient. Everything's healed up after a week. Donor area is healed, recipient area looks good, swelling's gone. But you'd be surprised how many people are self-conscious about having a razor shaved haircut. So I sometimes have people who take like 3 weeks off, 4 weeks off, but you can work out after a week after FUE. You can wear a loose baseball cap after 4 to 5 days, but everything's healed. It looks fine after a week. But after 2 weeks, people are more comfortable because the hair has grown a little bit, because it's no guard razor shave. With strip, I just shave the strip itself. A lot of times I shave the recipient area. And so, it's mainly just cosmetic, like waiting for the hair to grow back, things like that. But after, a week, everything's pretty much healed. With the strip, stitches come out 2 weeks later, typically 10 to 14 days later.
So you mentioned, the final result takes about, a year. Like what do you patients expect? You put all these hairs in, is it going to just immediately start growing, or what's that process like to see that final result?
It's a process. It takes time. So initially the grafts, they're very vulnerable to getting dislodged, because you're making these tiny openings, you're putting these grafts in, but it's not like they're glued in or stitched in. It's just a tight opening that's like this sucking in this graft. And so if you bump your head, you're going to knock grafts out. But after 4 to 5 days, the grafts start to take hold in their new location. And by a week, they're pretty much intact. But at around the 2-week mark, all the grafts, they fall out. And the follicle, which lies underneath the skin, goes into this dormant phase. And I gotta tell people, it's like it's hibernating. There's no growth for about 4 to 6 months. And then at about 4 to 6 months, the grafts kind of wake up and they start to grow. But they start out very, very fine, kind of like, baby hair. And they get thicker and thicker every month after. And the full result is seen at a year. So if someone contacts me at 6 months, 7 months, and they're like, my density, I think I need another session. I'm like, you have to wait. You have to wait a year, because your results at 7 months are not your results at a year. It's going to be different.
There is a trend, you're always analyzing celebrities, but there was a period of time where Justin Bieber was wearing like a beanie cap for months. It seems like he wasn't without it. He was his style or whatever. And then now people are looking at his hairline and seeing that from 10, 15 years ago, it seems like it's dramatically thicker, more forward. And is that, I don't know if you've been asked that question, or is that something that people have gone through the FUE, you shave things down and they're trying to hide that while it grows in for months and months of time? Is that a possibility? I won't hold you to it, but that as long as we have an expert, we might as well ask about a celebrity.
I've never heard about Justin Bieber, but he's so young, that I think, I don't know how old he is. To me, he looks like he's always 12. I don't know, but I'm sure he's
hair transplantation. No.
Yeah. But I think you can cover with caps, that's fine. But it just, the thing that's kind of, people on the internet, they've coined it the ugly duckling phase, where the first month, once the grafts shed, you get a little bit of shock loss, a little bit of just due to the stress of surgery. Injecting local anesthetic, epinephrine injections can trigger shock loss. So you get a little bit of thinning of the pre-existing hair. And so people have called that the ugly duckling phase, because you look worse than you did before the transplant. So I always tell people, be prepared, after around a month, 2 months, your pre-existing hairline is thinner. It might be a little bit of a pinkish hue where all the openings were, but that all goes away. The hair regrows. Any redness, any residual pink goes away. And then once the grafts start to grow, it just looks out, it looks great, assuming they have a good donor area.
Well, Sahar, I just fact checked, and Justin Bieber's 30 years old.
Oh, he is.
That's
well,
it.
we're old then.
He's in the zone. He's in that period. He's in the zone of age that you consider.
Then, yeah, it's a good age.
And then something else just came up as you were talking about genetics and treatments and medications and good donor sites and so forth. Is there a thing such as preventative hair loss, as far as, anti-aging? 20-year-olds are getting toxin, just to avoid wrinkles from forming and not having the muscle strain. Do you recommend, if someone has a strong family history or has the earliest hint of hair loss, to get on oral minoxidil and finasteride? Is that something that is a trend now, or are we waiting for it to become more moderate or more obvious?
No, actually, these medications work best when you still have hair on your head. I'm not saying everyone should go on it. No. But if you are starting to think maybe it's a little bit thinning, then definitely I recommend it. Because if you're bald and you go on this, it's not going to do anything for you. It's not going to work. It's not going to regrow the hair. It only works when you have hair on your head. And it doesn't, like I said, it doesn't work for everybody, but it works. It's the best treatment out there. So, and then, people get a little bit concerned because of the side effects, particularly finasteride. You go on the internet, and the biggest thing that people, freak out about, and there's even a website, I think it's called post-finasteride syndrome or something like that. But it's people get real worked up about the side effect, which is sexual dysfunction side effects with finasteride. But that's rare, maybe 4 to 5%. And it's, if you have an issue, you come off the medication, your side effect resolves. I've been prescribing it probably close to 10 years now. I've never had a permanent side effect. My colleague, Dr. Conyer, has been prescribing it for 30 years. He's never had a permanent, you have an issue, you come off of it, it's resolved. The half-life is 5 to 6 hours. Oral minoxidil, you don't have any of those anti-androgen side effects. It's a blood pressure lowering pill, so you have to be on the lookout for palpitations, dizziness, lightheadedness, fluid retention. At a higher dose, it's known to cause, there's a risk of pleural pericardial effusion. So with the hair loss dose, I've never seen that, but that's the thing to look out for. But, by and large, people of all ages, men, for women, oral minoxidil has been great because finasteride is not FDA approved for women. It's teratogenic. You can give it off label if they don't plan on having children, but it's nice to have something to also offer, oral minoxidil for them because they're not the best surgical candidates, unfortunately.
That was going to be my next question: is female hair transplantation? Are you doing
very tricky?
Yeah, because they tend to lose hair a little bit everywhere, right?
Everywhere.
They don't have that donor site that's as reliable. So how do you approach those? Are you doing mostly hairline or forehead reductions, hairline advancement? When is a patient a good candidate for a hair transplant when it's a female?
So I think I have probably, if I look at my hair transplants, 90% are male, 10% are female. And those 10%, the female patients are majority, almost all of them, probably pretty much nowadays, all of them are just hairline modulation. Or, facelift scar repairs, brow lift scars, things of that nature. So that's also another really cool thing is planting grafts into scars. We can talk about that later. But so with females, usually it's high hairline and they want to lower it. So you can either do that with a forehead reduction or a hair transplant. But if a female patient comes in and they're talking about diffuse hair loss and hair shedding, that's usually I just refer them to a dermatologist and, medical treatment. The reason why they're not great for surgical for a surgical option is a lot of times, unfortunately, women, when they get hair loss, it's diffuse, that's what you just said. And not only is it just diffuse everywhere, but the donor is also very thin. And that's where we're taking the hair from. They get diffuse thinning like here, and it's just not worth it. If you take out a strip and half of that hair is just thin, you can't transplant it, it's wasted. And then, you have to be very careful not to injure the pre-existing hair. So usually it's really conservative, small graft numbers, 800, or less, but something small like that is not even going to really make a big difference. So I try to, I offer oral minoxidil or finasteride, and then just have them follow up with dermatology. And I can't imagine that they have much better treatment options. They're doing the same things, offering the same treatments.
Are women happy with the hairline reduction or forward, forehead, shortening procedures? Is that, I have a staff member friend, who's keeps telling me to do that to her. And I'm like, I don't know how to do that. But it seems like as I'm examining her, I'm like, that's probably a legit, outcome, like a really good option for her in the right hands. What are those type of patients look like and how happy are they afterwards?
I'm very careful about who I select for that procedure. And I would say they are also very happy patients. I guess I never really, realized just how self-conscious people are about a larger forehead. It's never something I really paid attention to. And then, we trained with Dr. Kabakar, and he was just doing a ton of these. He's the guru on forehead reductions. And that's the first time I even encountered or heard of such a procedure. And, I think it's grown in popularity. I get people, other surgeons all the time on like Instagram messaging me like, hey, how do you do that? Or what, do you put an endotine? What do you, so I think it's become more and more popular. I think it's a really nice surgery. I do it under local anesthesia and oral Valium in the office. Takes 90 minutes to 2 hours. Recovery is a week. And I'd say patients are really happy with it, but I'm kind of particular about who I'm picking to do that. So I look for patients with relatively straight hairline, so no deep recessions, and a really thick hairline. If they have any hair thinning, then I don't want to do this on them because that scar will show. It's an incision along within the first, couple rows of hair, and you're following, the undulations of the hairline. You go back 2 finger breaths on either side, and the whole goal is for the hair to grow through the scar. And if they have hair thinning or if they have a colic at their hairline, then the scar will show. So the colic thing, I just tell patients, I'm like, hey, you have a colic, I have a colic right here. You have something similar from here to here, your scar might show because you have a colic. But if they have hair, and that's, not too big of a deal, because if they have a little bit of a scar exposure, just one little spot, you can always put grafts into it. But if they have just like a lot of thinning, extensive thinning, that you don't want to, do this surgery for them. So, but if they have naturally high hairline, really thick, relatively straight, ideally not too many colics at the hairline, they're a great candidate for the surgery.
Are you still elevating the whole flap under local and doing a drain and everything? Just like
No drain.
Endotyne? No drain?
Endotyne, yeah. No,
Endotyne,
during
yeah.
Dr. Kabacher, he didn't do drains. Did he do drain?
You didn't do drains? I can't remember.
You can't, yeah, no drain. Yeah, I do it exactly, same way. I use an endotyne. I place it right here. If I'm doing a brow lift, I put 2 here. You can do a brow lift through the same incision, dissect down. Usually you don't go too far down if you're just doing the forehead, but if you do a brow lift, you could do that at the same time. And
those patients were so happy.
What's that?
Those were pretty remarkable transformations for those patients.
Yeah, it's nice. And you might have during your year, I don't know if you ever did them on male patients. So it's not uncommon that I'll get a male patient say like, hey, can I do a forehead reduction? And unfortunately, I have to say no to that because the scar will very likely become visible, because almost all male patients develop some degree of hair thinning, and it can be just very mild, or it can go back a couple centimeters, and then that scar is forever there. So I know there are people out there who do forehead reductions on male patients. So I just think it's kind of unethical. Like, I don't want to deal with that.
It's too risky.
Too risky. Yeah.
So in our previous last season, we talked a lot about board certification, like, patient research, doing their homework. Hair transplant kind of seems, or restoration kind of lives in this, doesn't seem like anyone really owns hair restoration. I guess from your perspective, if patients looking for a surgeon for this, is there like a good place to go? Because I know, ER docs, IM medicine docs, plastic surgeons, facial plastic, everyone kind of can, in theory, dabble in this. But is there a good resource to find like well-vetted surgeons?
Yeah, so that is very true. I think more than any other procedure, I think hair transplants, you have a ton of other non-surgical specialties doing it, more so than, we were talking about, you mentioned liposuction, you'll have ER doctors doing that. But I feel like with hair transplant, it's almost like the surgeons are the minorities. It's uncommon to have a facial plastic surgeon or a plastic surgeon. Maybe general surgeon might be a little more common, but it's not super common that our fields are doing hair transplant. It's more internal medicine, ER, derm. But I'm not saying, I think as having a surgical background, you have a leg up because you're, from day one, you're using loops, you're operating under a microscope, drilling. For us, we're drilling the mastoid under the microscope. FUE, you're using like a microscopic punch. And then we also, as plastic surgeons, as facial plastic surgeons, we have that, we're seeing everything with an artistic eye. Designing the hairline is not just, make a line. There's a lot of artistry that goes and planning into, making it look natural. So I think, we're at a huge advantage, and I kind of wish more of my colleagues were doing this because I think we'd have, even better results. The problem is with hair, as you know, there's a lot of really bad results out there, even now where we've come a long way and you've got some amazing results out there, but there's still like horrible results. You still have people with like pluggy hairline. I've done in the past couple months, I can think of 2 people from out of town, one guy from Texas, another guy from somewhere else, came in, his hair was all forward and then he pulled it back, early 20s, and he had his hairline like right here and pluggy. And I had to take an FUE punch and punch out each one of these. And, it's like a mess, not to mention their donor is then, these are wasted. The donor is wasted. So, I think as surgeons, we see everything with an artistic eye. We have that, those skills, but you're right. There's a lot of other specialties doing it. And I'm sure they do a nice job, but the problem, like why it's attractive to other specialties is because, this isn't an insurance thing. It's all cosmetic. It's all out of pocket. And it's something you can delegate to low-level technicians. So if you're doing a rhinoplasty or a tummy tuck, you can't have your tech do the whole thing, but with hair transplant, you can literally just draw the hairline. Maybe if you're doing strip, take the strip out. FUE, you could have technicians do the harvesting. You might make the openings, but a lot, PAs can make the openings. Definitely technicians can place the grafts, and you can have like 3 people placing the grafts. One person might have more experience. The other 2 people over here, not much experience. And then you have like differential growth. You hear that a lot from patients. Like one side grew well, the other side grew not well. And it's because there's just no oversight. But so what can patients do? There is, I don't want to mention forums and things like that. I'm not really affiliated with that stuff, but they talk about us, our practice, but we're not giving them money or anything like that. But there's different hair loss forums, I'll say, on the internet, and like things like Reddit, where you just have to do a ton of research, because patients, a lot of times, not all of them, but a lot of them document their experience. They put their before and afters up there, and they are, it's the good, the bad, the ugly. Everything is on there. So you just have to do lots and lots and lots of research. You don't go with the flashy ad, like billboard on the highway as you're driving. You have to do a lot of research. And I feel for these patients, because so many people have been like, I just looked up a place, practice looked nice, clean, and I just did it. I didn't now they're out of business, it's like, so you just have to do lots of research. But, on the internet, people will document their story, and there's quite a few hair loss forums on the internet. Some of it is super annoying, the things that they write, patients will try to give out medical advice, and you have to kind of sift through that silliness, but you'll see real botched results. You'll know, okay, maybe do more research. If you were considering that person, maybe do a little more research, because this result is, everyone has not perfect results, but you'll be able to tell if you do enough research.
2 last maybe rapid fire questions for the expert. One is hair transplantation FUE a thing for like the male pattern that's at the top of the head, like the vertex, or are you strictly just treating like the frontal hairline? Like, is it
crown? This is the crown. Mm-hmm. You can definitely do crown transplants.
And then just to wrap up, the do's and don'ts of hair restoration, as far as non-surgical, we hit home about the medications and prescriptions. Is there anything that you feel is harmful that you've seen people come in, fly in for, and say, oh, I did this, and that's has been sabotaged? We talked about the poorly done, maybe the inexperienced, front line that's too low, or taking big giant hair plugs, the lack of having a board certified, surgeon maybe performing a majority of that. PRP, you feel like it's not helpful? Is there any other key things for our audience to not buy on Amazon, like a red light scalp cap or something else like that?
Fortunately, that stuff, it's pretty harmless. So if you want to try it, go for it. Some people they think it works. I'd say most people, in my experience, talking to my own patients, they don't think it works. But I think it's pretty harmless. It might just put a dent in your wallet. That's, I think, the worst part about it. But I think the takeaway points are hair restoration. It's great. It's a really nice thing to add to your practice, even if you're not mainly doing face, but it's a nice rejuvenating procedure. When performed well, patients are extremely happy. And you can really make a huge difference in patients' lives. Patient selection is really important. You want to try to be able to predict kind of what their hair loss pattern is as best you can. Obviously, no one has a crystal ball, but if they're a little bit older, their hair loss pattern hopefully has declared itself a bit more. Understand the donor area. It's finite. It's limited. No one has enough hair to fill everything. So patient selection is key. I think, that's pretty much it. Medication, non-surgical medication options are good, especially for people who still have hair on their head. The mainstay treatment, I would say at this time, Propecia minoxidil.
Awesome information. Thank you.
Yeah.
Yeah. Thanks for joining us. A good refresher, as I haven't really been doing much hair anymore and really focusing on the breast and body aesthetics, but great chatting with you. And I think this will be, really, provide a lot of information for patients out there. So thank you, and have a good rest of your night. And we'll throw your Instagram handle up there so people can find you and tag you, whatnot, if you're good with that. And
sure.
All right. Okay. Awesome. You have a good rest of your night. Thank you.
You too. Yeah. Keep in touch. Take care.
Awesome job. Thank you.
Bye.
Thanks so much for tuning into this week's episode of Fuller Butz, a behind-the-scenes plastic surgery podcast. Doctors Fuller and Butz are so appreciative of your time and attention. We invite you to subscribe, share, and continue to enjoy our plastic surgery perspective. Feel free to reach out on Instagram at either @FullerSurgeryMD or @DanielButzMD. That's Butz with a Z, for comments, suggestions, and support. Remember, be artsy, stay scientific, and make life fun. We hope you'll join us again on the next episode of Fuller Butz.